I represent the kidney transplant team at JIPMER, and I thank the scientific committee to give the opportunity to share our experience of what we had in renal transplantation over 2.5 years. And I am here to present the overview of our program. This is not truly scientific because the numbers we don't have to present the true data. This will be how the journey was, the hurdles we crossed, and how we get over with the help of the teamwork and the leadership. The whole thread will be the leadership and the teamwork. I'll keep repeating that again and again. So straight to the top, this is the timeline of our transplant program at JIPMER. We got the DTH's permission on 13th April 2011. And it took 1 year close to 1 year to us to get into the phase of doing the first transplant on 3rd March 2012. And next the event was the 10th July 2013, where we did the first laparoscopic kidney retrieval. And the mega event which happened, the disease donor transplant program, which was established in JIPMER on 5th December 2013 by performing the first one, which is first time in the Union Territory of Pondicherry. So just I go to these are our numbers. We have done totally 34 in 2.5 years. It is much better than the numbers of government hospital Pondicherry, where they started close to 5 years before us, and we are increasing in number every year. I accept the numbers are not too great, but it's every year we are increasing thanks to the cadaver program. So live donor 22, deceased donor 12, deceased donor. And now out of the live donors, mothers and wives are the most common donors as expected in our countries like India. Regarding the results, we had 2 mortality within a week due to inherent problems with the patients due to CKD, and both of them had well-produced kidney during the day. And 2 patients expired after 6 months due to immunosuppression related viral infections. Right, this is our first event, the kidney transplantation JIPMER, which happened on again 3rd March 2012. So all of us understand the kidney transplant is a multidisciplinary approach where we need to, a lot of people have to put their effort. It all started with we have to get the permission from the appropriate authority. So we have to collect the data from in all the departments of JIPMER. Imagine the size of the JIPMER, where each department has to contribute the data for past 3 years. All these were collected together, put in the filled up form 11, and we submitted our director submitted this application to the ministry. Then the competent authority came as a committee to inspect to their satisfaction. Then they gave the permission in April 2011. So after that, we started the ball started rolling, but in a slightly lower space, with putting a lot of things in place, the whole gamut of things like HLA matching, the procurement of the immunosuppressive drugs and perfusion fluid, the therapeutic drug level monitoring. The nurses have to train both at the theatre and the ICU, and the collaboration with other institutes for the mentorship of the initial couple of cases to kickstart and sustain the program, and also the post-transplant ICU, which is fully functional, good infrastructure and trained personnel. And also we need to arrange the theatre arrangement to have a twin OT to do the donor and recipient side by side. And also we need to get the dedicated vascular instruments and consumables, or like a vascular suture, which we are not having. And these things were all fast-tracked within very short time to achieve the day which we did the first transplant. At this juncture, I would like to mention thanks to the CMC team who came on that day and stayed with us for 2 days. The team headed by Professor Nitin Kekre. He is the head of urology at CMC Vellore. So I did the first transplant assisted by Dr. Nitin Kekre on that day, and the patient went on well. It was a huge success. We celebrated, and this is a small team, only the urology and nephrology. Unfortunately, we could not have any function. There were a lot more people were involved in the whole process. Right. So after having done close to 20, which is a sweet number to cross, after standardizing the techniques, standardizing SOPs, both surgery, nephrology, anesthesia, and other departments, and showing the reasonable success to the hospital and the society, then we wanted to move on the next level with the support from the administration. What we wanted to do was the laparoscopic kidney retrieval, which gives a definite advantage to the donor who are altruistic and giving the kidney to the near and dear ones. So then, even though we had enough experience of laparoscopic urological procedure at Chipman, both ablative and reconstructive, we went for a focused training. I went during my vacation. I went for 2 weeks training to Gujarat, for 2 weeks only for lap donor nephrectomy. I assisted there. And we came back. I went in May. We did the first lap donor nephrectomy in July. Successfully performed in a patient with accessory artery. So the patient and recipient occurred well. This was our another watershed event, and we are now regularly doing laparoscopic donor nephrectomy and with minimal, which causes less morbidity to the donors compared to the open donor nephrectomy. Only on the left side for that current status. But the culminating the mega event, which was the establishment of the deceased donor kidney transplant program at JIPMER on 5th December 2013. Which exemplifies the teamwork of the JIPMER to the community, that what we can do by this. So what the background was, the panel of experts, they went the certification August 2005, thanks to the coordinating report from the liver surgical team, and formulation and SOPs by the neurosurgery and neurology and other experts. We had a workshop, the transplant coordinator was appointed, and intensive care of the brain death donor before harvesting. This is a crucial thing to give us who can give the good kidney to us. Anesthesia played a tremendous role in that, and the SOPs for mobilizing the manpower and the infrastructure. That was the direct administrative involvement. People could be mobilized, and extra for simple things like fumigation, arranging nurses in the OT, and technical staff, all were done. Whom to contact? Our medical superintendent, additional medical superintendent, director directly involved in that. That's what made it happen. And all happened with the altruistic of a single, the family of a brain dead donor named Jagdish and our first patient. Like some of the cases, just to name a few because of lack of time, initially we started doing only on the clean cut cases. Then after doing 20, we went into the challenging cases like major vascular reconstruction of the bed. And this was a surprise to us. The cadaver kidney on the left side were 3 arteries. After thinking multiple options, we did with aortic patch of external artery. Lack of time, I'm not going into the detail of all this. These are the technical challenges for a surgeon. We successfully managed it with a good success. We did not waste any, no graft was lost, and artery anomaly, venous anomaly were dealt with a good success. The polycystic kidney, simultaneous nephrectomy and transplant in 2 phases. Okay, so what is the recognition of our work? We had recognition by the regionally and the other institutes in the JIPMER. We presented our work. We got the best paper award for our laparoscopic donor nephrectomy work. And we presented our auto transplantation work at National Conference at Delhi. And I'm proud to say that JIPMER helped SRMC to start the lab donor program in last vacation time in May 2014. This is what the minimum number we reached to 11. Okay, what's our challenges? In-house cost facility, I hope it will be done. Still, we are having the problem. Time delay in the legal hurdles for the keys donor program, and financial sustainability, which can be approached by endowments and the budget allocation and insurance and all. And long waiting time transplant. Now, average it takes around 8 months for live donor. That has to be increased, improve. And future, we want to go into multi-organ transplant, the pediatric and baby and compatible transplant. Capacity building in the form of training the young surgeons and the fellowships, both medical and surgical, the research and innovation in the immunosuppressive protocol. This is our future. I am going towards my end. This will be incomplete without saying the 2 things, one about the teamwork and another about the leadership. So this is a whole gamut of people who are directly involved. Departments were directly involved, even though in nephrology, urology, and anesthesiology, nursing team, the surgical aspect of transplant, but actually it involves a huge number of people. So this is the best example of the teamwork. And finally, the leadership. At JIPMER, currently we have leadership, our director, medical superintendent, additional medical superintendent, and the nursing leadership. They have a model. This is my own imagination of what I thought the current JIPMER model. The administration is the one which pushes the team from the behind for doing the better and pulls from the front. At the same time, the managers the everyday activity by directly getting involved into them, getting constant feedback from the people who does that, and also monitor in terms of safety, efficacy, and transparency. So actually, I can say that because with such kind of leadership, no team can escape without performing best to the best. So that is what the example what we have shown. It's not a great achievement, especially for people from US. It's a small numbers, small, but it's a baby step. We are progressing. That's what the message. So again, the key word is the leadership and teamwork for the kidney transplant. That kidney transplant is one which exemplifies from the Chikmagalur. Thank you.
Thank you, Dr. Muruganandan, for your overview of the renal transplantation program. Dr. Martin Filbert, the Dean of the School of Public Health and Professor of Toxicology at the University of Michigan, is also the chair of the US EPA Chemical Assessment Advisory Committee. His work has been funded by the National Institutes of Health, the Department of Air Force, and the National Cancer Institute. His focus is on flexible polymer nanoplatforms for the optical sensing of small molecules and ions. He has great interest and expertise in neurotoxicology and experimental neuropathology. On behalf of the team, Dr. Martin Filbert will be presenting today.
Director Rav Kumar, distinguished faculty, alumni, colleagues and friends, it's a great honor to be here today on your Founders' Day. 50 years of distinguished service and achievement is nothing to be sneered at and much to be celebrated. I'd like to give you just a few minutes view of the University of Michigan School of Public Health. Our mission is, like most other schools of public health, to seek to create and disseminate knowledge with the aim of preventing disease and promoting the health of populations. The structure of our school is quite simple, and it follows the CEF, or Council for Education in Public Health, criteria for an accredited school of public health. The 5 core areas are epidemiology, biostatistics, environmental health sciences, health behavior and health education, and health management and policy. Please forgive me for a moment, I'm going to brag. But our biostatistics department is ranked #1 by the National Academies of Science in the United States. This is a fierce competition. Approximately half of our faculty come from India and are actively engaged in research projects and in providing workshops with our partners across this nation and elsewhere in the globe. There's no such ranking for environmental health sciences, but we're generally perceived to be in the top 2 or 3 departments. Similarly, with epidemiology, there's no such ranking, but clearly an eminent group of scholars, including your own alumnus, Dr. Rajat Saran and Dr. Matt Bolton. Health behavior, health education, there is no ranking, but it's generally held in the United States that the University of North Carolina and the University of Michigan hold the 1st and 2nd positions in the nation, with a very strong emphasis on community engagement. And having described at the University of Michigan the principles of community-based public health research. These principles have now been adopted widely across the US and increasingly across the globe in getting those hard-to-reach populations, those who, for whatever cultural, religious, or other reason, will not engage with a health system or will not take up a healthy behavior or refuse to give up an unhealthy behavior. We're proud to also have within the school the #1 ranked Department of Health Management and Policy. And as I was listening to the presentations earlier this morning, it became really quite apparent that there is much that we can learn from each other. You have access to cases that we have rarely seen in the United States. You have deep public health problems in your populations. The number of men who still smoke, the growing number of women, the uptake of unconventional forms of tobacco by young people, and increasingly drug abuse and alcohol abuse, all provide challenges to what we have traditionally seen as the government-funded healthcare system. Both in the United States and here in India, the idea of providing free care is no longer sustainable. How do we meet the challenges, our ethical obligation to protect the health of the public while providing high-quality services to those most in need? This remains the challenge for all of us. Brand new in our school is a joint program with the School of Information, where we have begun to offer the joint masters in health informatics. This program is a little different from those that you may have heard of at some of the schools in the United States, which have a very strong focus on the electronic health record or electronic medical record. Our program seeks to fuse the principles of public health, of the social and economic determinants of health, and to combine with what is known about the patient's medical status, provide input back to, or feedback back to the individual to help them manage their disease. Managing chronic diseases as we get over the acute burden of infectious disease and life-threatening acute diseases has become the challenge for us all. How do we manage diseases like diabetes? And how do you live healthily with diabetes for 40 years, 50 years? What kind of information systems can you use that are based in the evidence that will help promote health? Our school, like the rest of the campus, is incredibly collaborative. Unlike any other university I've been at, the University of Michigan is an exceedingly interdisciplinary and multidisciplinary place. In fact, when I became the Senior Associate Dean for Research many years ago, it was my job, and the Dean told me it was my job to remove every administrative barrier that I could to allow the faculty to engage with each other. It is not uncommon for faculty in epidemiology to be dealing with faculty in the social sciences, or in engineering, or in chemistry. In fact, my career in nanotechnology for the detection of small molecules and ions and the early detection of brain tumors results from collaborations with neurosurgeons and engineers and chemists and so on. It's incredibly easy to do. And in order to foster this kind of interdisciplinary research, we have interdisciplinary centers, and you'll hear about one of them, the Kidney Epidemiology Cost Center, housed in the Department of Biostatistics. These centers are completely open to collaboration with anyone intramurally within the University of Michigan and extramurally. We have very strong links to the world-famous Institute for Social Research. This has one of the largest survey research centers in the public or private sector, and the Institute of Gerontology, the International Institute, and the Graham Environmental Sustainability Institute, just to name a few. For those of you that will be collaborating with us, please don't view this memorandum of understanding as being being limited to engagement with the School of Public Health. We provide for you a gateway to the enormous capabilities on campus in Ann Arbor. Just a few statistics. Our research volume to date is $1.44 billion annually. Not cumulatively, but annually. It's a staggering number. And virtually all faculty are engaged in some sort of research. About $751 million of those dollars annually come from the federal government, 39 million from industry, and the rest comes from foundations, global, local, and national foundations. We rank number 3 of all universities in the United States in research activity and number 1 of all the public universities. A recent ranking of global universities places us at number 15 in the world. This is the trend. This data is a little bit out of date, but we have now gone